Hi, everyone. Welcome to our webinar called Talking Post-Transplant Acute Myeloid Leukemia, Improving Outcomes After Relapse. My name is Gail Roboz. I'm a professor of medicine, and I run the leukemia program at Weill Cornell Medicine in the New York Presbyterian Hospital in New York City. And it is my great pleasure to welcome my friend and collaborator, Dan Pollyea, who's a professor of medicine at the University of Colorado in sunny Mountain, Colorado. Dan, welcome.
Thanks, Gail. Great to be here.
So a couple of housekeeping things first. Our educational objectives, we want to examine the need to improve outcomes in post-transplant relapse in AML patients, identify methods to detect post-transplant relapse accurately and in a timely manner, evaluate the potential of novel maintenance therapies in improving outcomes in post-transplant relapse and or in preventing it, and to also implement individualized approaches to effectively treat and manage patients with post-transplant relapse. And without further ado, let's get into the topic at hand. So we're talking today again about relapses in AML after transplant. And the first thing is a little bit about AML. So AML is actually the most common acute leukemia and is among adults, and it's a genetically heterogeneous disease, and it's our most common indication for allogeneic stem cell transplantation. So there aren't that many people with AML, although you wouldn't know that coming into my office or to Dan's office, but it's still considered a rare disease. But with relative overall survival at 5 years not looking so great, of 30%. We have a lot of new toys in AML, and I'm going to talk about them. Our strategies are better than they used to be for sure, but still, of the 20,000 new cases or so a year that are diagnosed, unfortunately, still the majority of patients with AML do die from their disease, despite the advances that we're going to be talking about throughout the lecture today. So when you talk about AML, it's actually gotten a lot more complicated. And this slide alone, which I put these colors on just to make sure everybody is awake, but ELN 2022 risk stratification was actually just published recently. And it's important to sit for a minute and digest the table because there are some changes that really are quite important. And I used to say for years and years that, AML comes in 3 flavors, good, bad, and medium. That's still sort of true, but it's not as obvious as you'd think to risk stratify your patients. And getting this right actually shapes the entire patient journey of what you're going to be offering them from the beginning of their treatment all through the post-remission zone. So the favorable diseases, favorable still doesn't mean that you're going to live forever, although that's what the patients want you to tell them. Core binding factor leukemias are here, A21s and version 16s. It's important to know that those can often be in association with a FLT3 mutation. That doesn't change our initial strategy of trying to treat those patients for cure with chemotherapy without stem cell transplant. We also have in that group mutated NPM1 patients without a FLT3 abnormality, and these BZIP in-frame mutated CBP alpha patients. These are more rare to find, but it's important to kind of recognize the name and recognize the abnormality in your next generation sequencing report. The first 3 here are molecularly categorized diseases that are followed in the post-remission setting with PCR testing. So it's important to get that right out of the gate. And it's important also to start thinking about these joint reports of cytogenetics and next generation sequencing, which for many docs don't come in the same file. And it's complicated because it might even be coming from 2 different labs, and it's certainly going to be coming on different days. So there's a lot of kind of a jigsaw puzzle that needs to get put together, which is why I'm spending time on this slide. Now, things get more complicated even as you move on, because most people are used to seeing, for example, a FLT3 and thinking, well, that's got to be adverse. That means bad things, except now it's landing both in combination with a mutated NPM1 and in combination with a wild type NPM1 in the intermediate category, as long as there aren't further adverse risk cytogenetics. So this is a little bit of a change for people because I think they're kind of used to seeing a FLT3 and immediately calling it adverse risk. And things like 9/11 too, people are used to looking at it and thinking it's adverse risk, but it actually isn't. It's in the intermediate intermediate category. And also cytogenetic or molecular abnormalities that are not classified as either favorable or adverse fall here, but that means you have to know how to read your cytogenetics. And I used to tell people that all you have to do is look for a lot of commas and semicolons, and then you know you've got something bad. But even that's not true anymore because, for example, you'll see highlighted in yellow that complex karyotype, except for hyperdiploidy, is in the adverse zone. And I just had a patient walk in and I had everybody on my team telling me complex karyotype adverse, except it was a hyperdiploid patient. And this is hard. These are hard to figure out. So my whole warning about this slide, and I promise I'm moving on now, is linger on your reports. Make sure, find that complex karyotype, find that monosomal karyotype, which is only one abnormality, but it's monosomal, that's adverse. Don't look at a TP53 and think you necessarily know what's going on because they're looking now for variant allele fraction over 10% to call it adverse. And all of this relates to the rest of my talk, which I will finally get to, about what are you actually going to do with your patients. So now you've done a great job. You've assessed them. You have all of your data back. You've comprehensively profiled them. Are you still ultimately deciding whether they're getting 7 and 3 or not? Well, kind of. It's not that black and white. So here you have a red for ineligible for intensive chemo and a green for intensive chemo, as if that would be an obvious decision. It isn't. There are patients who crisscross between those who might be eligible for intensive therapy, but you may have a rationale to go with a lower intensity strategy out of the gate. But I just want to call your attention to the hatched lines at the bottom, all of which lead to purple, which is stem cell transplant and or maintenance. So there are different paths to get to a transplant. My co-conspirator tonight owns some very nice data about patients who are treated with hypomethylating and venetoclax-based therapies, but going on to stem cell transplant. So they were in that red zone, except they still landed at the purple in the end and are getting a stem cell transplant. So there are lots of ways to decide who should get a stem cell transplant. And why are we even talking about this? Because what we've been saying to people forever and what we still say to them is that actually allostem cell transplant offers the best chance for cure. Doesn't cure everybody, but it's still the curative therapy that we have. And if you look on the left, those are the data for intermediate risk, 40 to 60 years old. You can see that chemotherapy just doesn't cut it for those patients. We try to shuttle them onto an allo transplant. This is intermediate and actually for adverse risk. We do try to get all of those patients under 60 to transplant. But if you look at the older than 60 patients, which is the majority of those with AML, these are data from the Hutch, okay? The Hutch knows how to transplant patients. They're good at it. And yeah, it's true that the majority of patients who are older than 60 don't ultimately get a transplant. But when they do, and when they get one in a place that knows how to do it, the outcomes are actually quite good. And if you look at the difference between, years ago and what's happening in the last decade, those outcomes are getting better. So actually, over time, even though I would love to get rid of transplant, we are transplanting, I would say, more patients. More older patients are actually getting onto transplant than they were in the past. So now we have to figure out how to optimize this. So the data that led to us transplanting all of these patients are relatively old. If you go all the way back to 2009 in JAMA, these were looking at a meta-analysis of 24 intent-to-treat trials with 3,500 patients. We're not going to get 24 trials again with 3,500 more patients. This was a donor, no donor analysis, and this is what drove the argument to transplant patients when you can with intermediate and adverse risk. But we know that we're not curing most of these patients, despite the fact that they're getting what I just said was the only potentially curative modality. So what happens, unfortunately, disease relapse is the most common form of transplant of transplant failure in adults who get transplanted for AML. If you look at the cumulative incidence of post-transplant relapse, it's between 30 to 70%. So a 70% relapse rate after your allegedly curative therapy is obviously obviously not what we want to be looking at. And the outcomes for patients who are transplanted in second complete remission as opposed to first complete remission are poor, with survival rates that are measured in months. So the question obviously is how to get these numbers to change, how to not be dealing with the treatment of relapse after transplant, how to optimize the patients for transplant, and once they get to a transplant, how to keep them in remission. So initially a polling question: which of the following abnormalities is associated with an adverse risk in AML per the 2022 ELN risk stratification? A mutated NPM1 without a FLT3, a mutated NPM1 with a FLT3 ITD, a wild-type NPM1 with a FLT3 ITD, or a translocation 816. And just to go backwards to where we were before in talking about this, that this is tricky. So the adverse risk here is going to be actually for that 816 translocation. So it's just tricky. Don't get distracted by the FLT3. Now, moving right along. So what is the role of MRD in AML transplant? Now, this is a complex topic, and the whole point of this is trying to figure out now how to not have patients relapse after our curative modality. So here, what we know is that MRD, or measurable residual disease, formerly called minimal residual disease, we don't like that because minimal makes it sound not important. So measurable residual disease is associated with inferior outcomes. If you are able to detect it, pretty much however you detect it, MRD positivity has an adverse prognostic impact on overall survival as well as disease-free survival. This doesn't tell you how to solve the problem. It just tells you there's a problem, right? Knowing that you're MRD positive doesn't mean you don't do a transplant. It doesn't mean you know that if you give 23 more cycles of chemotherapy, you can get rid of it. But it tells you that you're concerned about having a problem with that patient. And the measurement modalities here are numerous. You can look for flow cytometry-based disease in everyone with AML. You can also look at PCR and its sequencing, but the PCR and the sequencing data are complicated to interpret and not necessarily applicable for everyone. PCR-able lesions are NPM1 and core binding factor mutations. DNA sequencing is not necessarily routinely done in the post-remission setting for follow-up. This is a complex area with a lot of clinical trials, but no matter what you are looking at, whether it's flow PCR or sequencing, the detection of residual disease is of concern in AML, and it does have a negative prognostic impact. It also has a negative prognostic impact in the context of allostem cell transplant. So if you look here, this is again meta-analysis data looking at 19 studies. Pre-transplant MRD, no matter how you measured it, wasn't a great thing to have. Again, not telling you not to do a transplant, but telling you that you are more concerned about the outcome of that patient because you know that it's not going to be as good as it should be, as good as it would be if you had MRD negative disease prior to the transplant. So what do we do about all of this? Well, it starts making you think about, okay, if I have something that is going to impact my overall and disease-free survival, what are things that I could do? So one controversial thing, but that gets some airtime, is what about changing the type of transplant that you're doing? Not saying I'm not going to do a transplant, but what could I do that would be different? And these are very interesting data that are getting explored about the use, for example, of cord blood transplantation or an alternative donor in patients who have MRD. And this was a very interesting paper looking at cord blood compared to HLA-matched and HLA-mismatched transplants. You can see survival data and relapse data were actually favoring the use of cords here. So the question is it possible that having a cord blood transplant could actually mitigate the negative prognostic impact of having MRD? Not everybody can get a cord blood transplant, and not even all centers do this, but I think AML doctors look carefully at these data when we know that we have somebody going in MRD positive. Now here, looking at the effect of the number of induction courses on cord blood transplant. So we've often worried about it in the past that for AML patients who take more than one cycle to get into a good remission or to get MRD negative, is that somehow indicative or concerning for a fundamentally more resistant disease? Here, looking at comparisons of outcomes of adults that underwent cord blood transplant in first remission after 1 or 2 induction courses, they had engraftment lower for patients achieving remission after 1 versus 2 induction courses, but all the other outcomes were similar. The non-relapse mortality, relapse incidence, leukemia-free survival, suggesting here too that the cords might actually have solved for the fact that 2 induction courses might have been associated with a more resistant disease biology. So something to think about. It's not a webinar to say that everybody needs a cord blood transplant, but something to think about. Now, what else could you do to try to solve for the problem of a patient who's going into a transplant with MRD? Well, what about the impact of the conditioning regimen itself? So we know that reduced intensity conditioning regimens have been developed to minimize early toxicity and deaths after allotransplant. And many of our older patients in that 60 plus and 70 plus group would be anticipated to need a reduced intensity transplant. They're not going into fully myeloablative transplants. And here we have this slide refers to a phase 3 study examining the efficacy of a reduced intensity fludarabine-based conditioning with a standard regimen with AML patients in first remission, with a similar incidence of non-relapse mortality and reduced toxic effects compared with standard conditioning, but long-term reporting that there was no increase in the risk of later relapse. The reduced intensity was compared to myeloablative in another phase 3 trial in patients with AML that showed a reduced, again, level of treatment-related mortality, but higher relapse rates. So is it okay to use a reduced intensity conditioning? Did it associate with increased relapse? Here, if you look here in the MRD positive setting, these were data that Roland Walter published a few years ago, saying that the intensity of the conditioning regimens did not actually reduce the risk of relapse in the MRD positive setting. This was as measured by flow cytometry. So looking here that the 3-year relapse estimates were 28% and 57% for MRD negative and MRD positive patients, respectively. But if you look over here, there was an effect modification if you looked at next generation sequencing analysis of patients. So these were data from Chris Hurrigan showing clearly that if you look at this NGS positive group, so the purple hatched line for NGS positive patients who got a reduced intensity conditioning, clearly there was actually an impact of the conditioning. So the point here is to discuss carefully with the transplanter what can you do to be maximally intensive. So I think there is a push to have older patients going into transplant with whatever is the most myeloablative regimen that they can actually successfully tolerate, and especially given that most of these patients, or at least many of them, are in fact positive by next generation sequencing when they go into a transplant. I think it's worth it to look at these data carefully and see what you can do about your transplant conditioning regimen. Here, looking also at, this is fundamentally an immunotherapy, right? Transplant is the ultimate immunotherapy. So looking at pre-transplant MRD and post-transplant chimerism, if you look here at the mixed chimeric patients in the yellow curve who are MRD positive, not looking that great. So here too, another thing to be tracking, that if you're able to have establishment of full chimerism, maybe that is a way to actually solve for the negative impact of MRD out of the gate. But if you have patients who have mixed chimerism or who have poor chimerism, those patients who are MRD positive aren't going to do well. So these are a whole bunch of different strategies, looking intensity at conditioning, looking at chimerism, looking at the donor source of ways to try to solve for the problem of having leftover AML at the time of your transplant. Now, here's a hard question. Which of the following statements is true for the role of MRD in post-transplant relapse? A, pre-transplant MRD is predictive of worse leukemia-free survival. B, a reduced intensity conditioning is preferred for MRD negative patients. C, cord blood is the preferred donor source for young patients with AML. Or D, 2 induction courses increases the probability of MRD after transplant in AML. So I'm going to give it to the majority here. So the majority of the respondents are saying that A is the correct answer, which is that pre-transplant MRD is predictive of worse leukemia-free survival, which is in fact the case. And I am going to move on to the next slide, which I am going to I will toss that to Dr. Pollyea, who will continue with novel approaches to prevent relapse after transplant.
Well, thank you so much, Dr. Roboz. I'm, just as you said, going to continue in this vein. And I think, because we have such relatively poor options from a salvage perspective in the post-transplant setting, I think the name of the game really is how do we prevent that from happening altogether? And, we know people like Dr. Roboz and others in the community are working hard to develop those salvage options, but I think it's incumbent on us, until we have that magic potion to treat a relapse after transplant, to see what we can do to prevent it from happening altogether. And I think we're going to talk about some of these intriguing possibilities that are, both here and ready for prime time, as well as some that are in the hopefully in the very near future. So, first, just talking about treatments we actually have access to. Hypomethylating agents have been around for a very long time in our field. And it's been very, very appealing to think of them as potential therapies in the post-transplant setting that could prevent relapse from occurring. There have been a multitude of relatively small, many single-arm studies that have been very provocative, and summaries are listed here for your reference, very provocative as potentially able to do just that, to prevent a relapse from occurring after transplant. There have been problems with many, if not all, of these studies. They are all fairly small. It's difficult to look at any randomized data in this setting, but very intriguing. Most of them very intriguing as having a signal for being able to do this, or at least delay a relapse at the very least. So we do have data from a randomized trial a couple years ago published in Blood Advances, and this was really designed to answer this question in as definitive a way as possible. And patients were randomized in the post-transplant setting after stable engraftment to either receive azacitidine at a sort of lower dose and less day schedule than we typically use it, or observation. And patients were sort of expected to receive 12 cycles of therapy if they were randomized to therapy. And this was a fairly large study. This was actually 187 patients that were enrolled and randomized. And somewhat disappointingly, there was no signal with respect to response and the difference between these two groups with respect to relapse-free survival or overall survival, as you can see the sort of overlapping Kaplan-Meier curves there. Now, I think that despite the conclusion by the authors of this being a study that was relatively safe, there was a lot of discontinuation of the azacitidine, and the median number of cycles was only 4, when again, the intention was for patients to receive 12. And yes, some patients didn't get the full complement of azacitidine because of relapse, but many patients, I think upwards of 40%, came off for toxicity or logistical issues. And so the question can be asked as to whether this was really the definitive study showing that this is not effective, or if it just wasn't effective because the patients randomized to the therapy didn't actually receive as much of the therapy as they would have needed to get the effect. And so I think it's not the definitive study that we had hoped. And it also raises this very thorny issue that post-transplant setting is a difficult time to introduce an intervention. Patients are just getting over a transplant. There's a lot of other therapies being expected of them. Many patients that get transplanted at their transplant center go off into, back to their home center. So it's hard to do clinical research in this setting. So a lot of challenges here. And I think folks in the field would not consider this too discouraging to not continue. This was another trial, a bit of a different setting that the Germans did and published a couple years ago. In this case, they looked at patients who had achieved a remission, some of whom had achieved a remission after chemotherapy, some of whom had achieved a remission after an allo transplant, but who at the time of remission had MRD. They were in a remission, but they had MRD. And as Dr. Roboz explained earlier, that's a bad prognostic factor. They then intervened in these cases and gave the patients azacitidine in these patients who had this situation. And, it was a single-arm, non-randomized study, but certainly very promising. There were some patients who were able to flip from MRD positive to MRD negative, and that seemed to have good implications. And I think that, this showed some feasibility and set us up for, later clinical trials that were done as well, with the intention of maintaining patients, particularly such as the one Dr. Roboz was involved in with oral azacitidine, in that case, not in the post-transplant setting, but in the maintenance after induction chemotherapy setting. So, again, I think a promising signal that this could be an effective strategy. And in the post-transplant setting specifically, here's a summary of other of those HMA studies. And again, it's a difficult, challenging place to do clinical research. Many of these studies are small, with maybe one exception on this list. These were not randomized studies. So sometimes you look at the results and you say, well, that looks pretty good, but compared to what? And so this is a challenge, but I think, again, one that we still have considerable enthusiasm for as a field to pursue. And I think a lot of these trials, particularly the oral azacitidine, which has shown benefit in the post-chemotherapy maintenance setting, for maybe potential there. Now, some patients have particular gene mutations that we can intervene upon and maybe sort of bend the curve in the post-transplant setting and allow for assistance. And so, in the era we're in now with the FLT3 space, we have all kinds of super specific FLT3 inhibitors, but in the kind of recent era before the era we're in, we had very non-specific FLT3 inhibitors that we sort of borrowed from other indications. In the case of sorafenib in the kidney cancer setting, where sorafenib is a pretty decent FLT3 inhibitor that has some considerable off target side effects. But there has always been some enthusiasm for using sorafenib as a FLT3 inhibitor, and over the years that's been shown to be effective. In this case, the Germans had a nice study design where they took patients with FLT3 positive AML, took them to a transplant, and then maintained them either on sorafenib or a placebo. This is sort of the dream scenario, maybe with the exception that by today's standards, sorafenib is not the best FLT3 inhibitor, but really got the study design, et cetera, right. Now, the primary focus of the primary endpoint of this trial was relapse-free survival. And this study had to be ended early because of poor accrual. But even with that sort of caveat and the lack of power to really look at the study, they met the primary endpoint of relapse-free survival. It was a statistically significant difference. It didn't meet criteria. It didn't meet the same statistical significance for overall survival. But you can see by those trends that it definitely signal was heading that way, and who knows what would have happened if this had been able to be completed. So, we know that sorafenib is maybe a good post-transplant intervention for FLT3 positive patients, but we're really limited again by the fact that sorafenib has a lot of side effects, and this is a difficult place to do clinical research, and toxicity is real in this situation. Now, our colleague Keith Pratt's led this similar trial, where they used sorafenib. About half of them received sorafenib in the pre-transplant setting, about half of them in the post-transplant setting. This wasn't compared to a control group. So again, all we have to look at is event-free and overall survival that looks pretty good, compared to sort of maybe our usual expectations here, and also showed some feasibility that in at least this small group of 44 patients, this was possible to do. Toxicity profile was manageable, et cetera. So, I think FLT3 is targetable, but we would all like to move on to the era in which we are, in which we have very specific and relatively better tolerated FLT3 inhibitors, in this case, gilteritinib. And so this is the hopefully definitive study that the entire transplant community is participating in, a large study randomizing patients to receive either gilteritinib or placebo in the post-transplant setting. And I think we're all very interested and anxiously awaiting these results to see if we can see some of the similar promising data that we saw in the SORMAIN study with sorafenib translated into this more specific and hopefully better tolerated FLT3 inhibitor. Now, folks have done some sort of meta-analysis type studies with the available data that we have. And, maintenance after a transplant with either HMAs or FLT3 inhibitors, you can see kind of the sum total of what we've got. And, these studies are all relatively small, but when pooled together show very clear signals that these are at least should be valued as potential strategies going forward, and how best to use these, and which is the preferred therapy. It's a little hard outside of the controlled setting that we like to see in the setting of a phase 3 sort of standard study. We may or may not have that for some of these. We hope to have that for gilteritinib, as I said before, maybe oral azacitidine or other HMAs being developed here, but certainly promising. And I would hope that in the future, this is something that we can actually be doing to help prevent relapse in our patient population. So I'm going to go with another polling question, and let's see if I can do it as well as Dr. Roboz. So which of these agents has shown efficacy in a randomized trial for FLT3 ITD AML as a maintenance agent after transplant? A, quizartinib; B, crenolanib; C, sorafenib; D, none of these. Thank you. So yes, the majority of folks have selected sorafenib, and that is the one that we have randomized data on. So moving forward here. So what do we do when we actually have a relapse in the post-transplant setting? We've all done our best to avoid it, prevent it. What can we do? This somewhat complicated algorithm I can take you through is reflective of our current practice. In the setting of a relapse, if a patient isn't having active GVH and they are have immune suppression going on, with the input and care of a transplant doctor, you can taper immune suppression and see if you can get a response back, basically reawaken that graft versus leukemia response. that's something that we should always try because it's relatively easy to do. Comes with the caveat you could flare the GVH, so you have to be careful. It doesn't usually work, but it should be tried. And if that's the case that it doesn't work, then we should look to see, is there a targetable gene mutation? That's always our first preference. We have FLT3 inhibitors now approved. We have IDH inhibitors approved. So that's the logical first step. If that's not the case, then, if they're a candidate for intensive chemotherapy, you could go that route. You could try to get them under control with a lower intensity regimen with the hope that maybe you can get them to a second definitive therapy, a DLI, or a second transplant. A patient who's having active GVH and is relapsing is a really tough problem. In that case, you don't really have the option of tapering immune suppression. So, again, you go through this algorithm, you think about if they have a targetable gene mutation. If so, that's your go-to. If not, it's a tough road to hoe. This is a very place where we would all strongly recommend a clinical trial, of course. Getting patients in this situation to a second transplant or a DLI can be considered as hopefully a definitive therapy, but outcomes there are very, very poor. I kind of alluded to this before, but this is a tough place to do drug development. In the post-transplant setting, you'd worry about flaring GVH. You worry about, all the immune suppression you're already on. These patients are already on a lot of different therapies. It's a tough road to go down for industry to kind of take this on specifically. As we showed you, accrual, even with the best efforts, that German group is an accrual machine, and they had difficulty. So, this is a tough place to be. And then, I think to some degree, the transplant community has their specific focus, and then, the drug development non-transplant community has another focus. But, I think there's a couple of different ways to generally think about this. When you don't want to be in the situation with the blue line where you're dealing with relapse disease, it's a difficult position to be in. Therapies don't work very well. You'd like to be where the green or red are. You'd like to be treating when you see MRD. That's what we would call sort of a preemptive therapeutic strategy. But the best would be to just maintain a deep remission and never have to deal with this, get through some period of time in the post-transplant setting where the immune system can really just sort of take care of this, gobble up all the residual stem cells and cure the patient. So, that's the dream scenario that we kind of want to be in. So, the drawbacks obviously for treating relapse disease is that's a big, tough job with a lot of competing interests. When you're in the preemptive therapy group, that would be a good scenario to be in, but you may not always identify these patients when the MRD is rising. And then, maintenance therapy, you have to accept that you're going to overtreat some population of patients who might otherwise do fine and didn't really need a maintenance therapy because they were never going to relapse. So there's challenges to all of these situations. It's just for informational purposes, here are some of the intensive chemotherapy post-transplant experiences. Some of these are baked in with a DLI or a second transplant. Some of these are just chemotherapy alone, but I draw your eye to the far column. And, responses are pretty poor. I think these are not the responses our patients certainly want to see. And we as a community definitely want to be doing better as well. And then we don't do much better or any better in the realistic situation where a post-transplant relapse patient is really not a candidate for intensive induction chemotherapy. And so if we're trying to think about lower intensity strategies, also some of the experiences summarized nicely here, but I draw your eye to that final column. And even though some of these are fairly active and can have been reported to allow for remissions, long-term or even short-term outcomes are pretty poor. So we're not, again, I kind of alluded to this before, we're not very good at this. Sometimes we have targeted therapies. That was in that algorithm that we talked about FLT3, IDH. So, this is the preferred strategy because the therapeutic intensity is lower. And at least in some cases, we think that these strategies are better than intensive chemotherapy. Certainly, if a patient can't tolerate intensive chemotherapy, this is the only option. Once again, even though this is the treatment of choice and this is the standard of care, we're not satisfied with these outcomes, and we need to do better. Immune therapies are really compelling on paper for a post-transplant relapse because the thinking is that you can sort of reharness the immune response that you kind of maybe started with the transplant, but that stalled out after a period of time. So donor lymphocyte infusions, always considerations. There's from the beginning been a lot of enthusiasm about checkpoint inhibitors to sort of reawaken this graft versus leukemia response. There's mixed results there, but very small numbers. Look at the middle column with the numbers. We're talking, barely double digits. And then some other, things that, may have more promise, but are very early development. Getting a patient to a second transplant is really the only chance of a meaningful long-term survival as far as we know today. But, those are not great numbers, but can be the goal and maybe should be the goal for some cases. Venetoclax has revolutionized non-transplant AML, so it only stands to reason that we should be thinking about it. And this slide says post-transplant AML, but really we should be thinking about this in the peri-transplant AML setting. So Jacqueline Garcia had a really nice recent paper talking about incorporating venetoclax into a conditioning regimen. Great idea, and some really compelling outcomes there. And then, maybe some strategies to use venetoclax maintenance in the post-transplant setting. There's a company-sponsored trial, the Viality study, looking at AZA venetoclax in the post-transplant setting, which I think is a really good idea. I think, all the challenges we talked about before apply with respect to trying to get a patient through, but definitely a worthy thing because we know venetoclax is so active in AML in general. It's very tempting to want to incorporate it into the peri-transplant setting. And then a number of other sort of cellular therapies, similar to the immune therapy slide we talked about, that I think are of interest for the community and should be considered for sure when this is faced with this scenario. Looking for clinical trials that can harness some of these very exciting potential therapies should be a priority. Okay, so another polling question here. So which of the following is true of preemptive therapy? A, it is provided when the patient is in, it is provided when the patient's in a molecular CR. B, it's provided upon detection of MRD. C, it's provided after clonal evolution of disease, or D, all of the above. This is something that with like we define preemptive therapy would be B, where you're looking for an intervention at the time of detection. So let's get into the case studies. And so I'd like to present the first one. So this is a 40-year-old male with relapsed AML. So this was an interesting recent case for us. 4 years prior, had presented with polycythemia vera and had been treated with phlebotomy, hydroxyurea, but then unexpectedly progressed to AML with 40% blasts. He had an abnormal karyotype listed here, and he retained the JAK2 mutation. He received 7+3, had a haplocore transplant. You heard a little bit about that from Dr. Roboz. With flu-cy, thiotepa, and TBI. And then 4 years later, relapsed with 60% blasts, a more complicated karyotype, again, just the JAK2 mutation. So in this case, what therapy or approach would you choose? A, an intensive reinduction. B, venetoclax azacitidine. C, ruxolitinib. D, decitabine. Okay. So, I think there's, I think, an intensive reinduction, certainly appropriate, depending on the patient and the shape they're in and their goals. Maybe a venetoclax-based regimen, decitabine as well. I think ruxolitinib is sort of the red herring here. It's tempting to say, hey, let's go after the JAK2 mutation, but there's really no data that type of intervention would move the needle here. So, I think the others would be probably preferred choices, but tough to really give, a one right answer on this type of a case.
Yeah, no, I think, Dan, it's a great case to bring up, because I think that it shows what we unfortunately know to be the case, that you can do everything right. And in this case, you did pick the transplant modality that would have perhaps the strongest GBL type of effect in a patient who might have had residual disease on the way. Certainly difficult to have a secondary in an MPN setting, and yet there's still a relapse. Although here you have a relapse a long time out. So again, hopefully the patient's in good shape and could be responsive. If I have to take a wild guess here, I'm thinking you probably did an HMA ven reinduction strategy. Just taking a guess. Is that what you did?
Well, yeah. So we did, in the context of a clinical trial, I will say, because I think if someone were to call me and ask what to do, given this patient's age, fitness, and like you said, the length that he has been in a remission, I think, the logical thing based on the history and his responsiveness the first time to induction would probably be to go with a standard 7+3. But, like we've talked about a million times, clinical trials are always the preferred approach. And so we did do a venetoclax-based regimen in him, but, just going with straight up venetoclax-aza for a young fit patient who's been in remission this long, I think it's deviating from standard of care a bit to do that outside of a trial.
I do think, though, it's fair to consider, what might have been a cumulative anthracycline issue here, and you're talking about a potential second transplant, et cetera. One could make a case for it that even in a fit person with a likelihood of an initial chemo-responsive disease, that how much anthracycline do you want to pile on? And I don't know exactly what his cumulative exposure was. I will say that in the chat, there is a specific question related to secondary versus de novo AML in terms of post-transplant monitoring. So the first part of the question is, should any part of the management change for secondary versus de novo in terms of post-transplant maintenance or monitoring? And then the second part of the question was clinical trials that specifically focus on secondary AML after MDS or MPN. So let's do the first part of that first, that anything different if you've got a secondary AML patient in terms of post-transplant maintenance or monitoring?
Yeah, I think this is a great question. I mean, I think, we would be more concerned, our antenna would be up more for a relapse in a secondary AML patient than a de novo AML patient, just because I think in general outcomes are worse. We would definitely, I know a lot of maintenance clinical trials are written for patients with high risk for post-transplant relapse. And some of those criteria, would certainly include MRD going into transplant, but others would be something like bad risk disease or something like secondary AML going into a transplant. So, outside of a clinical trial, which, is sort of the only official way to do post-transplant maintenance, I would say that these are patients, a secondary AML patient, I would be very tempted to kind of think of creative ways to keep them from relapsing. And in the future, I would expect that if some of these therapies are approved, it would be with, sort of a label that includes a higher risk population. What do you think?
Yeah, I think that it is absolutely, the sort of blanket answer of you're worrying about these patients more because something was the matter with their marrow to start out with. So whether it was MDS, whether it was an MPN, you're kind of worried that marrow is not a friendly zone. I would say that specifically the monitoring techniques, which is what the question was, No, I mean, you're just worried more. And I would say post-transplant MRD by flow at day 30, you don't want to see that. And you are going to be scrambling for something either on a trial or off a trial, but you're going to do something about that. And that's irrespective of whether they're secondary or not. I think it's interesting to think about, the obviously CPX-351 is approved for secondary disease or MDS with, myelodysplasia related changes. I think that the 5-year transplant data actually for that group looked very good. I mean, the original trial data for CPX versus 7 and 3 showed that benefit that resulted in approval. And then the 5-year data, which have been published, look actually pretty good for transplant, suggesting that, again, there too, it looked like the CPX patients, for whatever reason, they actually did better out from transplant than 7 and 3. So it wasn't just getting the patients into remission. But I don't know. I mean, it's actually a controversial zone specifically for the MPN patients, the secondary patients after PVERA, after ET, and then there's this complicated zone of accelerated versus blast phase for those patients. Some of those patients, just note to the audience, do end up in the post-MPN setting or the accelerated phase MPN. Those patients pop up with IDH mutations, so don't forget to check for that, because that's a zone that we can throw in an inhibitor. But I don't know, what's your feeling about secondary with the antecedent disease being MPN versus MDS?
Yeah, I mean, I think it's a great point, and it's a good distinction, because we lump those together, like you said, as secondary AML. In those groups, usually it's dominated by AML from MDS, and many clinical trials, as you know, even exclude patients with post-MPN AML. And so it makes them even harder to treat, because we have to extrapolate a ton from, other patients, once drugs get approved, or we can't find clinical trials for them. I think in general, AML from MDS is very typical, in this population of, the median age of AML is 68. Many of these patients, if not most, did evolve from MDS. So I think, the experience or expectations with that disease are sort of baked in. But, AML from MPN is tough. They do really poorly. Looking for clinical trials specifically for that entity is a good idea. Those are hard to come by. But I think if the specific question is clinical trials that focus on one or the other of these, it's definitely worth looking for and asking about. But at the moment, like you said, this is a great, role for CPX-351 for the, that's a labeled indication for those patients in the upfront setting. Beyond that, it's a tough population.
Yeah, and I think your point about that they're mostly excluded from trials is actually the problem, but it's definitely, I would say there's a smattering, of data for Veneza for getting the transplant, but just straight up front for the transformed patients from MPN. And I have to say that there's plenty of work that can be done there. So not looking resounding. I want to make sure, though, that before we close, that we have just a minute to look at the second case. So this patient was actually is my patient, and I think that it just brings up so many issues. So she's 42, healthy. She pops up with a FLT3 AML. She gets 7 and 3 and midostaurin and is in a nice remission and goes for a cord blood transplant with fluthiotepa cyclophosphamide. She got TBI and she relapsed 3 months later, which was an aggressive out of the gate relapse with still FLT3 positive. And I put her actually on decitabine and sorafenib. So I got to tell you, there were data at the time, you got to go backwards in time. I still think sorafenib does have some magical properties. It's a tough drug for sure, but it does things that are not only FLT3 directed. And I took a shot based on some very interesting in vitro data that had also come out right at that time, looking at some synergy. So I took a shot and I got lucky, and she was back in remission, doing great. The graft looked great. She looked great. We had said we were going to do a second transplant. And then we kind of said, oh, well, maybe we'll do it next month, and maybe we'll do it next month. And yeah, but then the kids had something going on. So we kind of forgot to do a second transplant and then said, oh no, now what do I do? Because she's on these ongoing cycles. And I went around and asked everybody who I thought, was important about FLT3. And everybody said, well, don't stop that. I mean, she looks great. So I wanted to kind of ask you and just have the audience think about it, that, how long, and this came up in our discussion, that how long is maintenance? And this is a nasty drug. And actually, she didn't want to switch and I didn't want to switch. And then finally, after a while, the sorafenib was kind of really banging things up, and that this is literally years later. And we said, all right, we're going to watch everything really carefully and make a nerve-wracking change to gilteritinib, which she is currently on an ongoing CR. But I just thought I'd throw it out there for you for the last word of okay, AML is a dangerous disease. We will do anything to keep it into remission, but it's hard to not be cured after you're supposed to be cured, and ongoing therapy is tough. And I don't know. My motto is, if it ain't broke, don't fix it. And I am a chicken about stopping people with dangerous diseases when they are in maintenance. But what do you do?
Yeah, I mean, great case. And it's, it just shows you've seen, one case of AML, you've seen one case of AML. I mean, I think, if you can see that her graft is healthy, she's had stable engraftment. I see that, the patient relapsed with an NPM1 mutation, which gives you an opportunity to potentially monitor for MRD at a very low level. And if you could do that somewhat serially and find that there's, a rising clone, maybe that would prompt you to reconsider and move quickly into a second transplant. But otherwise, I think there is some, magic to these post-transplant interventions when you do them quickly like you did, that can kind of reboot the graft and get things back on track. And, I agree, if things have gone this well for this long, I would continue. And if she's tolerating the gilteritinib, which, many people do, it's fairly well tolerated. I don't see a time point on the horizon where I would say, okay, now let's stop. So I think that's probably what we would do, is really lean heavily on the MRD.
Yeah, I think it's a great point to just bring up food for thought for some of the audience too, about what do you do if you have a patient like this patient who's sort of at the original time, the whole NPM1 story wasn't actually clear at that time. And if you don't have sort of the original PCR data and the original tracking, then if you introduce it later on, you don't really know what to do, because a lot of these patients are not going to be fully undetectable. They may have low copy numbers and they may have very low disease. And then kind of how do you track that? So the world of tracking in molecularly defined disease is a challenge. I think that's a great sort of ending statement to say, that always zero in on an NPM1 mutation now and try to monitor it. But if you've got a patient who's a few years out, I don't know that I would start monitoring now, because you might have to just monitor how much Valium you're prescribing for introducing a lot of anxiety. But I want to just make sure that we get to our I think this one we actually are going to, we can see what the audience thinks. So what would you actually choose for this patient? Sorafenib, gilteritinib, midostaurin, or another clinical trial? And we'll take you backwards in time. So the question is, what would you choose at the time of the original relapse? And I'll take a quick look at what everybody is saying there. And we've got a lot of votes, a lot of favoring for gilteritinib, which is totally understandable. I think the data have shifted, and that is a well-tolerated drug. We don't know definitively yet that that's going to be the survival benefit drug, but understandable answer. And just switching to our last slide. So in conclusion, I think we have convinced you to worry about relapse. So relapse is the biggest obstacle to success of allotransplant, and targeted or immunomodulatory agents should be aggressively studied and preferentially to prevent, as Dan said. We want to be preventing rather than treating relapse. We want to get patients onto these trials as much as is feasible. Agents likely work in concert with donor-derived endogenous or exogenous cytotoxic lymphocytes, so it's a combo effect of drugs plus the new immune system of the patient plus cellular therapies that might be applied. And transplant investigators and industry partners need to collaborate. We want this more than anything to have these clinical trials in collaboration so that we can actually answer the questions for our patients and prevent their relapse. And thank you very much for joining and for your participation in the polling, and have a good afternoon, day, evening, wherever you are when you're watching.